Good morning. Tom Gehring here, the Executive Director of the Medical Society. I want to report to you the results of the trip we just took to Sacramento. Myself, plus the physician leadership, plus some of our up-and-coming leaders, went to Sacramento and talked to all of the San Diego legislators, talked to the CMA folks, and I wanted to outbrief you on the results of that. The first thing I would tell you is that the battle of the week, of the month, is going to be scope of practice. And specifically what you see is that allied health professionals, whom we absolutely have to have, it's not as though we're dissing them, the allied health professional leadership wants to expand the scope of practice by removing physician oversight. The optometrists, the pharmacists, the nurse practitioners, the physical therapists, all have submitted bills that in one shape or another say the following: we want to do stuff without a physician supervising us. The position of organized medicine is that we want to make sure that allied health professionals do what they do best up to their level of training, but not to supersede the physician. And so our position has been bring more of them into the table, but you can't do doctor stuff. You don't know what you don't know, and we want to make sure that a physician is always supervising an allied health professional, because those are the folks that went to med school. So that's certainly a challenge that we're facing, and we'll have to deal with those. The second major issue deals with the health insurance exchange, which is really an implementation of the Affordable Care Act. And the executive branch is writing a lot of regulation, is trying to identify process. The legislative branch, the folks we talk to, is still writing enabling legislation for a number of the specifics associated with the health insurance exchange. What's important to remember is that effective 1 October of this year, they're supposed to be standing it up. The problem is the technology isn't done. The legislation, the regulations aren't done. We don't know which health plans are going to be participating. We don't know which health plans are going to pay what rates. So there's a lot of unknowns with the Affordable Care Act in California covered, which is the name of the health insurance exchange. We want you to realize that there are a lot of unknowns, and as soon as we have more information, we'll send it out to you. But you also need to realize that the health insurance exchange is the 800-pound gorilla to be. There's a lot of folks that are saying whether in 3 or 4 years they're going to have 20% market share. So we need to keep an eye on it, and we are, and you need to stay tuned to it. And as we put out information, please pay attention, and we'll put out lots of webinars on the matter. Third item on the table is opioid abuse. The Los Angeles Times ran an article, a series of articles about a small number of physicians who are abusing opioids. What we want to make sure is that we don't throw the baby out with the bathwater, and specifically that the regulations that get put in place allow opioids to be prescribed to patients who need them, so that we don't make it impossible for people in need, but at the same time we don't want to allow abuse. So that's the balance we always strike in opioids, and in fact in life, between overregulation and over-permissiveness. The fourth item on the table is graduate medical education. We're asking for the state to come up with the money to replace the residency training slots or funding thereto that was cut by the feds. So there's a lot of discussion now about how do we make sure that in time when there's a doctor shortage, that we don't cut the dollars associated with graduate medical education, read residency training slots. The fifth item is we want to make sure UC Riverside gets stood up. Right now it's the first 2 years for 50 students. We want to increase the number of students. We want to increase that to a 4-year program. By the way, it's not a 2-year program. It's 2 years are in Riverside, 2 years are in Los Angeles. But we want to make sure that there continues to be an increase in the number of physicians who are trained in California, hopefully who stay in California. And the third major impetus on increasing the physician workforce is to increase the number of Steve Thompson scholarships that will reimburse residents to the tune of about $105,000 if they practice in an underserved area. Then we talked to a lot of folks about the Medi-Medi transition, the transition from healthy families to Medi-Cal managed cares for kids. That's a done deal. There's not a lot that we can fiddle with on that. But the Medi-Medi, the dual eligibles, Medicare, Medi-Cal folks, we want to make sure that transition does not harm the patient and retains the doctor-patient relationships. There was a lot of discussion about keeping that intact. As a sidebar, that conversation, excuse me, that transition has now been pushed delayed at least twice so far. Now that transition to Medi-Medi to Medi-Cal managed care will occur no earlier than 1 September. We've done a lot of work to ensure that there are patient protections, that there are physician protections, but that's something that needs to be on your radar screen. There are two things that we did not have to talk about, the proverbial dogs that didn't bark. One is MICRA, which keeps our medical malpractice rates in check. With a two-thirds majority in the legislature, there's a lot of concern by folks that the lawyers are going to bring a bill that raises eligibility, or basically changes the malpractice environment. The good news is that for at least a decade, and probably more, your medical society, your dues dollars, your physician leaders' time has been invested in making sure that we elect pro-MICRA Democrats and Republicans who don't forget where they came from with regard to malpractice and the law associated with malpractice. So the good news is, while there is a two-thirds majority in both houses, we have worked very hard over a very long period of time making sure we elect pro-MICRA Democrats like Tony Atkins, who, when lawyers come through the door, says you can have anything you want, but you can't touch MICRA. And so that's really important. The other dog that didn't bark is to make sure that accountants, we love our accountants, but we don't want them practicing medicine, or more to the point, telling doctors how to practice medicine. So we want to continue to have a bar to the corporate practice of medicine so that doctors are directing healthcare, not accountants. Those two dogs, MICRA and the corporate bar, did not bark, and that's a good thing. I'll leave you with thoughts on where we are in the federal world. In the federal world, the big thing for us is finally crack this doggone GPCI, Geographic Practice Cost Index, that which keeps Medicare rates in San Diego 5% lower than they should be. The good news is that between San Diego and CMA, we've developed a no cost to the government, hold the counties who are currently overpaid harmless. The problem now is, as the old rule is, hold your enemies close and your friends closer, that there is a couple of Congress people outside of San Diego. We've got great support from Darrell Issa and the rest of the San Diego congressional delegation. But there's at least one congressman who wants to make the fix that we created for California a national fix, which of course is the kiss of death, because the rest of the nation hasn't figured out how to make that revenue neutral. So the beat goes on. As I like to kid Ted Mazer, they will probably emblazon the GPCI fix on our tombstones, but it will be a posthumous award, because we're feeling like this has been going on way too long. But believe you me, we're working hard on it. I know that the officers for CMA were in Washington, D.C. a month and a half ago working on the problem, talking to our senators. Excuse me. The other issue that is going to percolate is the sustainable growth rate. We know that come December there is a program, roughly 30% cut to Medicare. That won't happen because the cost of that is just too high. However, we're working very hard to make sure that we don't swing the pendulum too far in the other direction, that in interest of reducing costs, that the legislators do stupid stuff with regard to how they pay physicians. So the SGR is a little bit further on the horizon, but it's still there. Finally, before I turn the floor over to Dr. Sherry Franklin, our president, just want to remind everybody that we had a great Cures event. Cures is the database that lets you know whether your patients are abusing drugs, connects with the opioid issue. We had 123 physicians who were, last Friday, who made it into the Cures database. So that's the kind of thing your medical society is doing. I'm now going to pause and allow Dr. Franklin to take the floor and kind of brief you on her perspectives as the president.
Sherry Franklin, I'm your current president. I wanted to expound a little bit on our trip to Sacramento that Tom alluded to, amplify the political scheme just a bit. Specifically, what we went up there to talk about with our legislators was the Hernandez scope of practice bills. That's what we call them. There's a number of groups. Keep in mind that Dr. Hernandez is a doctor of optometry, so he was representing the optometrists in their attempts to assure that they can do surgeries and prescribe medicine without supervision or without referral to an ophthalmologist. The other groups, the physical therapists, the midwives, the nurse practitioners, and the pharmacists, then went to Dr. Hernandez and kind of tried to latch on to his direction with the optometrists. The physical therapists want to be able to diagnose and treat patients without a referral from an orthopedic surgeon. The optometrists want to practice surgery and possibly, I'm thinking, LASIK and things of that nature, maybe cataracts. The nurse practitioners want to practice medicine without supervision. We have a number of concerns about that I'll get to. And the pharmacists would like to actually prescribe medications or change medications if the patient is not meeting therapeutic goals. So that means that they would be checking blood pressures, checking hemoglobin A1Cs, or the like, or maybe lipids, and adjusting your medications. And I'm not sure how the information would get back to you, but they say it would. Our concerns with this and our arguments to the legislators was that first, this would be dangerous to the public because these people just aren't trained to diagnose and treat and adjust medications. They haven't had the extensive training that we have in those particular areas. We're also really concerned that there would be a split level of care. I mean, if you take a look at this, the whole impetus on these scope bills is to try and get people into indigent areas because there aren't enough physicians in the workforce. The last argument we made when we were talking to the legislators is the nurse practitioner avenue to try and save money because they cost less to train and to put out there, and ideally they would cost less in terms of salaries. But Kaiser's already done this, what we call pilot project. They looked into seeing if expanding the nurse practitioner role would actually save them money, and what they found was it didn't. Nurse practitioners understandably prescribe more. I mean, they do more tests and they refer out a little bit more. And so in the end, the cost was higher, and you might as well just hire physicians. So they went back to doing that and dropped the workforce of nurse practitioners down. So that argument carried a lot of weight. We also came to our legislators with some solutions to this problem. Rather than doing something dangerous or providing someone who doesn't have the appropriate training, we need to increase the physician workforce. It's something we all know, that we have a shortage of physicians, especially in California for the population. So rather than provide poor care, we asked the legislators to increase the funding for, say, UC Riverside, which, by the way, has their first incoming class this year. We're very excited for them. The second thing is we want to strengthen the Steve Thompson Loan Repayment Program by adding the ability of private practice primary care physicians to take advantage of this program. We still haven't figured out how to acquire more funding for the program, but at least we can get more people involved and more people that can take advantage of the program. I thank you, and we're doing a lot, so keep tuned.